On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, take a preliminary look at the proposed CMS 2025 HOPD ASC Payment Rule, discuss our upcoming conferences, and in our focus segment, we talk about timeouts, including an interview with Bill Duffy, who has been referred to as the father of the timeout.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 225 of the ASC Podcast with John Goehle for July 13th, 2024, recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of the recording. As such, it's important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
We hope everybody's enjoying their summer. We're recording this on a Saturday afternoon, a beautiful day here in Spencerport, New York, and hopefully everybody's getting an opportunity to enjoy the beautiful weather out there this summer. We had a drop-in session this morning, Sue, like we do for all of our patron members, and we had a very small crowd, didn't we, today?
We did.
Very personal service for the people that were there, but this kind of happens during the summertime. We will experiment a little bit, perhaps, of moving it from our Saturdays to our Fridays. So keep an ear out for that if you're one of our patron members. And if you're not a patron member yet, of course, visit ASC-Central.com for more information. And next week, Sue, we're going to be hosting our 8th Administrators Bootcamp. With over 250 graduates over the past 4 years, our bootcamps are the ASC industry's most comprehensive preparation for leadership in an ASC. I couldn't believe it. I had to add up because, we've been doing it so long. I didn't really figure out how many we've done, but this would be our 8th boot camp. So we're very much looking forward to that next week, and 4 days beginning on Tuesday. There is still time to sign up. It all depends upon when we drop this episode, I guess. But and of course, if you do miss the live virtual conference, the on-demand version is always available, again, at asc-central.com. And that's not the only conference we have coming up, isn't it? We've been planning a lot of things for the rest of the year. We are going back and re-recording our infection control conferences. We've been doing this since 2020. During the midst of the pandemic, we started doing these virtual infection control conferences, largely because we realized that people needed another avenue for learning about infection control oversight in the ASC environment. And our conference, our virtual conference, which is also recorded and available to purchase after the recording, has become really the gold standard for preparing nurses for the role of the infection control coordinator. So we have 2 courses, Infection Control 101, which is going to be on Thursday, September 16th, 2024. And the course focuses on developing the basic skills for an infection control coordinator and how to develop and maintain an infection control plan. Training on infection control plan oversight is required by CMS and by the accreditation organizations, and our program has always passed surveys when surveyors are looking for proof that your infection control coordinator has been trained. And then on the following day, on Friday, September 17th, we're going to be doing Infection Control 201. And this program focuses on more advanced topics in ASC infection control. And it is a companion to the ASC Infection Control Coordinator Training 101. And the program will provide information on performing the annual IP, infection prevention, risk assessment, performing infection prevention investigations, and preparing for surveys. And the two courses together really will help prepare you to take the CAPE exam, the CAIP exam, which is not required by CMS yet, but we do know that over time that probably will become, kind of like the de facto proof that somebody has the education and training to be able to carry on the role of an infection control coordinator. And then in November, we are about to announce, so you're hearing this first here, our on November 14th and 15th, we're going to be doing the multi-state conference again, the ASC Virtual Multi-State Conference. We did it last year in June. And this is a conference that we're offering free to state associations. So if you're interested in joining us for this conference for no charge, you might want to reach out to your state association to ask if they are participating. And if they are participating, they'll be able to provide you with an access code to participate for free. So that's all being rolled out over the next week. So hopefully you'll be hearing about that within the next couple of weeks. And this year's conference is going to include sessions on infection control, human resources, life safety, HIPAA, and breach notification, accounts receivable oversight, pharmacy, and survey preparedness. More information is going to come. If you're not a member of one of the participating state associations, you can pay the nominal $399.99 fee. And what's really attractive for this conference is it will offer 16 AEUs and 4 IPCHs. It's kind of an easy and inexpensive way to meet your requirements for your CAPE and your CASC certification. And if you are a board member or a leader in a state association and you don't know anything about this, please reach out to us. You can email us at info@ascpodcast.com, and we'd be glad to provide you more information. Again, this is we offer this service free to the state associations, and they in turn offer it free to their members. But you do have to sign up for us so that we can set you up in the system. And Sue, last week, the 2025 CMS HOPD ASC Payment Rule was dropped. You and I have not had a lot of time to go into it. I think that being said, I think we've both spent a couple hours looking at it, but that's still not enough to really delve into it too deeply. So we're just going to talk about it a little bit here and kind of introduce it. And then once more information is available and once we've had a chance to digest it a little bit more, we'll go into more details. I'm going to provide a link to the proposed payment rule in our show notes. And it will give you a 60-day comment period, which ends on September 9th, and the final rule will be issued in November.
And one of the overall comments we wanted to make is they have updated the payment rate by 2.6%, which is the hospital market basket increase of 3% that they reduced by 0.4% productivity adjustment, which is mandated by the Affordable Care Act.
So this is very disappointing considering our inflation. We might remember last year, I can't remember the number, but it was like 3.7% maybe. And that was considered low, considering we know over the last couple of years, inflation has been certainly on the rise. And I think one of my major concerns is while the inflation rate itself might not reflect the true costs in the surgery center, we know that things like salaries are going up dramatically. We know we have supply shortages that are causing increases in many of our supplies. So I do fear that, again, this payment increase of only 2.6% this year, which is actually kind of in line with previous years, even before the pandemic, is just going to be woefully inadequate for us to, as an industry, to keep up with our increasing expenses. So I'm very worried about our problems with attracting, paying for our staff. And it's not just nurses, as we've talked about.
Yeah.
You know, our techs and even back office people, the people in the reception, in the business office, they are demanding higher wages now, too. So, and certainly 2.6% is not going to be enough to deal with that. And then a couple other details from it. And again, we'll go into more details later on, but a couple more fine points here is CMS has concurred with ASCA's request, and they're going to continue to align the ASC update factor with the same factor that they're using for the HOPD payments, meaning that they're going to continue using the hospital market basket, at least through the end of 2025. And CMS is proposing to adopt a few new measures for the ASC quality reporting program. We're not going to go into any details because we really have no information about this yet, but they are going to be following in the footsteps of what's happening in the hospitals and developing some measures with regard to a facility's commitment to health equity and screening for social drivers of health. Now, Sue has been giving me a little bit of an education on some of this because those are things that she experienced in her time with hospitals. But I would say, as we were talking about offline, that it's going to be different for surgery centers and not something that we generally have had to deal with. And in my view, it sounds like we're going to be having to gather additional information as part of the pre-op screening process as well as the intake.
Yeah, and I'm sure people that have either just gone to a doctor and been asked these questions would know this, but social drivers of health, they generally include food insecurity, interpersonal safety, housing insecurity, transportation insecurities, and utilities. And I kind of like, though, that they're calling it now, I've always heard of it referred to as social determinants of health, and they've changed that to social drivers of health because they just want to stress that people have some choice in this, that these aren't things that are going to determine poor health. They're hoping to address some of these things and be able to, change that fate or those health outcomes.
Yeah, I think the concern that I have when I looked at this information is this seems to be something that's more in line with what you would be doing in a clinic or in a physician's office.
Yeah, with your PCP, probably. Somebody that's going to be following you for long term and can help you address those things. I think some things, if you're writing somebody a prescription to take an antibiotic after they leave your place, or it can be useful to know, can they even afford that prescription? Do they have a way to get to the, pharmacy or something like that? But for the most part, these are things that I agree should be addressed with your primary doctor care. Or if you're getting discharged from a hospital.
Yeah, and again, we'll know more about it once we get some more details here.
Yeah.
There were a number of new cases added or procedures added to the approved procedure list, meaning the approved Medicare reimbursement list. I'm not going to go into any detail here other than to mention there's very few of them, and most of them are, again, dental procedures. So a couple of them are having to do with more complex procedures in rotator cuff repairs, some additional procedures with regard to cardiology, and then, as I mentioned, I think there's six. It looks like 6 new procedures in dental. So we'll go into that in a little bit more depth. Very disappointing. I believe that ASCA has indicated that none of the procedures that they asked to have added were added. So again, we'll get you some more details as more details come out on this area. Sue, that's not the only news going on. Why don't you give us an update?
The FTC ban on non-competes, which we've talked about in an earlier episode, is now on hold due to an injunction issued by a federal court in Texas. The ban was to take effect September 4th. The court will be making a ruling on August 30th to decide if they are going to go forward with that. The FTC estimates the rule would retroactively void up to 30 million non-compete agreements across the country. And I think, as you were saying, it's so hard for ASCs to get staff.
Yeah.
And that's kind of the issue with this, is if you're putting a big investment into somebody, you don't want them to just be able to walk out the door after, a couple months or something like that. So, I mean, there's two sides to this, but I do think it's more challenging for ASCs. Yeah,
and it does impact our physicians also who might come on board and have, as part of that their operating agreement or their agreement to purchase into the facility. Obviously you want to keep them there and you don't want them to leave, as you kind of said, or implied, I should say, that just because they found a better, price somewhere else. So more to come on that. Like you, Sue, I don't know really, where to stand on this myself. I can see both sides of the story, and I guess it all depends on what are the big drivers that you're dealing with right now in your own organization. And I saw an interesting article in Becker's about a Seattle plastic surgeon
who was fined $5 million for falsifying reviews and having patients sign NDAs. As I said, this was mentioned in Becker's ASC review, so I went to the Washington State Office of the Attorney General to get some more details. It's just hard to believe. The patients were told to sign an NDA only after they paid a non-refundable deposit of $100. The center also paid employees to post false reviews, and they altered the before and after photos before they posted them on their website. The agreement stated that the center considered anything under 4 stars a negative review and required patients to not say anything that would hurt the reputation of the office. Some patients were also required to waive their health privacy rights to allow a response to the review from the practice with their personal health information if they posted a negative review. I mean, that's not even legal. I just can't believe that the first person who read this didn't report it. I mean, it's just...
Or that it's clear that somebody is going to eventually... having worked with plastic surgery practices over the years, it's difficult often. They're very demanding patients, and I can see how it wouldn't take very long before somebody complained about it.
Yes. And in gastroenterology and endoscopy news, there was an article about smoke exposure in GI endoscopy. In a study conducted by Christopher Thompson, MD, the director of endoscopy at Brigham and Women's Hospital in Boston, he and his co-investigators measured the levels of smoke exposure during common GI endoscopy procedures, such as those that stopped bleeding, removal of polyps, and reducing the size of the small intestine during gastric bypass. The highest level of smoke produced was during argon plasma coagulation procedures, which was similar to the amount produced when smoking a cigarette. High levels of volatile organic compounds were detected in the smoke from many procedures, and they found the particles often remained just kind of floating around in the air for quite some time. The researchers suggested more studies to explore how to produce less smoke and how to mitigate the harmful effects, such as wearing different types of masks or having devices that would remove the smoke. And we know there's been a lot of conversation and some controversy, at least in New York, about whether the smoke evacuation regulations and guidelines actually apply to endoscopy or not. But I think it's something that they're going to be looking at a lot more everywhere.
Especially with this information, yes.
And Becker's ASC review on June 25th had a news piece about what they call post-procedure clawbacks, which was another thing that was really upsetting. This is when health plans reevaluate a procedure after completion to try to get some money back or find a way to avoid paying. An orthopedic group in Missouri has a department dedicated strictly to pre-authorization and post-surgery requests. They try to be prepared by making sure the doctors know before surgeries which codes were approved and requesting that the surgeons tell them of anything that changes during the procedures. They also gather information before surgery that they may have to give the insurance company during the post-authorization process. One payer requested almost 6,000 patient records spanning a 2-year period. So basically, even after the health plans have given pre-authorization and the patients have had the procedure, they could come back a year later and say, well, let me look at that again. Maybe we shouldn't have authorized that. That just...
Another way
I don't see how you can avoid that. That's
It's another way that insurance companies are trying to not pay, very valid claims.
Yeah.
And that's 6,000 patient records over a 2-year period.
Can you imagine the time consuming? I mean, even if you somehow win these, which this one practice said they often are able to save that money and not have to give it back, but they're spending a lot of money fighting that, and just providing all that information. And I guess, the insurance companies may hope that people will just
give up,
not have the manpower to deal with it.
Yeah, you bring up a very important point that I've, over my career, when I spent a lot more time in finance, obviously, I spent a lot more time in regulatory, but one of the issues that we found in finance, or when I was called in to assist surgery centers that were having problems with accounts receivable, when their accounts receivable balances were increasing, is that one of the common problems I found is that people just gave up and they never, tried hard. If they got a denial, it was just too much work, or they were so busy with everything else that they gave up on these things. And those insurance companies know that.
Kind of count on that.
And they count on it, right. And they just think, they'll eventually pay you, but you got to keep after them. But I guess this is kind of showing that even that assumption that they eventually pay you could be incorrect. We did have a recent experience, a very positive one here, where a surveyor in one of our centers, a surveyor that was doing a survey for one of our centers, brought up a very good point, and that is if a physician orders something like a 12-lead EKG on a patient at the center, we need to make sure that there is a verbal order written in the medical record for this and then signed off by the physician afterwards, just like you would for any drug that was administered. Mm-hmm. And this was actually a HHC survey, so I can actually refer you to the HHC reference, which is CRD 300.20, which states clinical record entries include treatment orders. So those of you that are HHC, you might want to look at that particular code and recognize that surveyors will be looking to make sure that all treatment orders, not just drugs, but other treatment orders such as the 12K lead. And it also goes for things in pre and post-op, similar like nebulizers, use of nebulizers, which I totally understand that. I just have never really thought about it as something that you would need an order for. So something to definitely keep an eye out for. We haven't talked about timeouts, Sue, since, believe it or not, episode 001, our first episode. We did that in 2018, and it was our first topic. And, of course, June 12th, 2024, which was more than a month ago, was National Timeout Day. And it was a time, it's sponsored by AORN to think about timeouts, to really emphasize the importance of timeouts to your staff. And we thought it would be time to talk about this. Actually, what happened is we were doing one of our weekly drop-in sessions for our patron members on Saturday mornings. And during that, our friend Andre brought up the fact that he knew the father of the timeout, Bill Duffy. And we were talking about how, it's sad that we kind of missed that whole week, we missed the timeout day and weren't able to talk about it on the podcast. So we decided, even though it's well past the National Timeout Day, that we would go back and revisit this. So what we're going to do is we're going to take a short break, and when we come back, we're going to talk about timeouts, and then we're actually going to do a skit. This is a re-recording of a skit, or a recording of a skit that we did in our first episode, and we would love feedback on whether you'd like us to bring back these skits. So let's take a short break, and we'll come back and talk about timeouts. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our Administrator Boot Camp and the Director of Nursing Boot Camp, and in 2023, the Business Office Manager Boot Camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central patron program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts, and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. So So when I was looking into timeouts this time around compared to 2018, I went to the ARN website, and there was quite a bit of information up there about timeouts. And there was an interesting quote from Lisa Spruce, who is the Director of Evidence-Based Perioperative Practice at ARN. And this is what she said. In the high-pressure environment of the operating room, taking a timeout isn't a formality. It's a life-saving pause. The National Timeout Day, let's celebrate the power of clear communication and encourage every OR team member to speak up for patient safety. And again, that was from Lisa Spruce, who is a DNP, RN, and Director of Evidence-Based Perioperative Practice over at ARN. And Sue, the website also pointed out that wrong surgeries were up 26% in 2023. That's a shocking statistic to me. And this is what they said. A reported wrong site, wrong procedure, wrong patient, and wrong implant surgeries increased 26% in 2023, according to new numbers from the Joint Commission Sentinel Event Data 2023 Annual Review. And leading contributors to wrong surgeries cited in that report include no or insufficient timeout procedures, preoccupation or task fixation limiting situational awareness, and no or inadequate shared understanding among team members. And I'm going to provide a link to that particular annual review because it was very interesting. And then also I'm going to provide a link to the latest evidence on best practices for timeouts and team communications in surgery. I thought that was very interesting.
And basically that just sounds like it's saying either you're not doing a good timeout or people are not paying attention.
That's right.
It's really that simple, and that's what we've seen so many times.
Well, and Sue, I do a lot of surveys and mock surveys, and I got to tell you, it is very rare that I see a good timeout, which is kind of sad, given how long they've been around. Now, timeouts are not directly referenced in the CMS conditions for coverage, but they are implied. Timeouts are one of the most proven methods to avoid medical errors, including wrong site surgery, wrong person surgery, avoiding administering drugs to patients when they have an allergy to them, et cetera. So if you want to see really the only reference to a timeout in the interpreted guidelines, you want to go to 416.43C, which is the standard for program activities, QAPI program activities. And I'm not going to go into any detail here because it really doesn't go into any specificity. But if you need to have, if your doctors are asking where the regulatory requirements come from, it is driven from 416.43C. Now, I did want to kind of point out two of the timeout references, one in HHC, and then we'll talk about Joint Commission also. So in the new V43 version of HHC, ASG.29 refers to timeouts, and it states the following.
A timeout is conducted immediately prior to beginning a procedure, and the provider performing the procedure assumes responsibility for the timeout. So I just wanted to make a note here. So even though that would sound like the doctor is responsible for running the timeout, I believe a nurse or somebody else can run it if the doctor is kind of taking responsibility for that.
Correct. Generally, I feel that they're compliant if the doctor says, okay, time out, and then the nurse runs the actual timeout. The circulating nurse runs the timeout. Okay. Though I've seen doctors run it too, and obviously that's totally appropriate.
Yeah. The entire team is engaged in the timeout. That's so important. During the timeout, the following items are verified: patient identification, intended procedure, correct surgical procedural site. All equipment necessary for performing the scheduled procedure is immediately available and functional in the operating or procedure room. Any implantable devices intended for use during the procedure were prepared before the procedure, and they are available.
So in addition to actually not seeing a proper timeout being performed, even if I do see a good timeout, often they're forgetting about that equipment. So that is something that, especially if you're a HHC organization, you do need to make sure that you're performing. Now, Joint Commission is interesting because it doesn't go into the same level of detail about what should be included in the timeout, but it does state, now this comes out of UP.01.03.01, and it states that you need to conduct a timeout immediately before starting the invasive procedure or making the incision. The timeout has the following characteristics.
It is standardized as defined by the organization, so always you want to keep in that same formula, kind of. It is initiated by a designated member of the team. and it involves the immediate members of the procedure team, including the individual performing the procedure, the anesthesia providers, the circulating nurse, the operating room technician, and other active participants who will be participating in the procedure from the beginning.
And when two or more procedures are being performed on the same patient and the person performing the procedure changes, you perform a timeout before each procedure is initiated. And then the Joint Commission goes on to state that during the timeout, the team members agree at a minimum on the following: the correct patient identity, the correct site, and the procedure to be performed. And it does state that you need to document the completion of the timeout. And Joint Commission goes on to state the organization determines the amount and the type of documentation. I found it interesting, Sue, because the AAHC spends a lot of time talking about all of the things that are required, and Joint Commission talks about the people that are participating. So if I put these two standards together, I think you really have a good idea of what really the surveyors are looking for here, because even though AAHC doesn't mention who is participating in it other than to say everybody, Joint Commission does go into a lot of detail. So I think a good rule of thumb is to kind of look at both of these standards and make sure you're implementing it in your own organization. Now, in 2018, when we started doing these podcasts, we did skits, which were kind of fun. They were little acted out vignettes. And our first one, in episode 1, we're going to show here. And Sue, you and I talked about this. We kind of would like to get some feedback from people. You know, is this too silly, or is it something that was really beneficial? And you and I listened to it again, you know, 5 years later to kind of figure out whether we wanted to include it in our much more polished podcast now. But we thought it would be kind of cute, funny, and we are interested in seeing what your thoughts are, because as we listened to it again, it really did. It was a good way of kind of getting everything across in a more humorous way. So let's listen to that vignette now.
So now let's listen in on Nurse Nancy, who is in the middle of an unannounced CMS survey with Sam Surveyor.
Well, hey, Sam Surveyor. What are you writing so furiously about in your notebook there? I've never seen anybody write that quickly. Oh my God, or never that much. Plus, I've never met anyone with such an appropriate name.
Well, I guess that's just fate. But getting back on topic, I just finished observing one of your procedures here, and I don't think they performed a timeout. Did I miss something?
Oh, no. We do timeouts all the time here. I mean, just last week, Dr. Persnickety put Scott the scrub tech into a timeout just for not genuflecting in his presence. What a guy.
That's not quite what I mean. You know, you have to do a timeout before each case where everybody in the room stops doing everything and double checks to make sure that the procedure is ready. It's quite a list of things that you're supposed to look at. They should identify the patient's name, the date of birth, the procedure that's being performed, the side it will be performed on, any allergies or anything else that you should know about the patient, and then verifying that you have the correct equipment and any implants or supplies that you might need.
Oh, you can't be serious. Everyone in the room? And that whole list? I mean, that's an awful lot of work for a very safe procedure. We almost never make mistakes here.
Well, let me give you an example. The room I just left is all set up for cataract surgery on the right eye.
Okay, so what's wrong with that?
Well, according to the medical record that I looked at, and actually direct observation of the patient on the table, you know, she's an 11-year-old girl there for a tonsillectomy.
Oh, but that can't possibly be right. I mean, for heaven's sakes, I am, well, you know, she's probably going to need cataract surgery down the line sometime anyway.
Nonetheless, I really recommend that you stop that procedure immediately. You know, it's just not going to end well.
I don't think you understand. The doctor's not going to like all this whole timeout thing. I mean, can't we just do one quickly, like before he even comes into the room? He gets really upset when we waste his time on our silly paperwork. And it's my job to keep him happy.
Well, the other part of your job as a nurse is making sure you keep your patients safe. I don't think you quite grasp the concept of a timeout. It's a critical step in your safety program to reduce the chances that you're going to do the wrong procedure on a patient or to do it on the wrong side or with the wrong equipment or implants. The doctor is an absolutely critical part of that process. He knows the procedure that's being done, the equipment and supplies he needs. It is really his responsibility to make sure that everything is ready for the procedure. But that's all part of the safety plan, which of course is one of the critical elements of your safety program. After you stop that procedure, which I encourage you to do right now, can you give me a copy of your safety plan?
Safety plan? What is that exactly?
Oh my, I think I'm going to need a bigger notepad.
Well, we hope you all had fun listening to our little skit there. And again, please provide us some feedback if you'd like to see us do some of the skits like that in the future. We have certainly a lot of good actors among our team here. So I think that it's definitely something we could do.
Unless, and feel free to say, please
Don't do that again.
Don't resurrect that if that's how you feel. There will be nobody will be offended.
Next, I'm going to have an interview with William Duffy. He is an RN, CONOR, FAAN. He's the Director of Nursing and Healthcare Administration for the MSN track at Loyola University in Chicago. And Mr. Duffy is the past president of ARN from 2004 to 2005. And during his tenure, he led the association's initiative for the National Timeout Day to eliminate wrong site surgery. And indeed, he's sometimes referred to as the father of the timeout.
Yeah, I found the conversation really interesting.
Yeah, it was. I enjoyed doing it. And what we did is we dragged Andre, and I know Andre so well, but I don't know how to pronounce his last name. So Andre, I am so sorry that I'm going to mispronounce
I think
this.
it's Abragamov or Abragamov.
Abragamov, yeah. And he's an RN, MSN, CONR. He's a big participant in our weekly drop-in sessions, a good friend of our podcast. He was on podcast at ASCA 2024 also. And he is the director of Ingalls Ambulatory Surgery Center at the University of Chicago Medicine. So let's listen to that interview now. So I'm here with Andre and Bill. Andre, you and I on Saturday during our patron drop-in session, which we do every Saturday morning, we were talking about timeouts. We'd actually had talked about it the week after the actual timeout week. And it was interesting because when I think back on my history, I've been in the industry since 1990, I just kind of always assumed that timeouts had always been there. And Andre, you kind of reminded me that that certainly was not the case, that there's quite an interesting history behind it. And I thought you would start by talking about your experience with timeouts over your career.
Thank you, John. I'm very happy to be here. Thank you for the invitation. Yes, it was a very interesting discussion at our Saturday session. We were sharing, it was a timeout day, of course, on June 12th, and I asked the group of how did you guys celebrate the timeout day, because I had so much fun educating my team about the history of the timeout, and we had a little trivia about how long do you think the timeout was? And I was very surprised about the answers that I was hearing. People thought that timeout was introduced in 2010. Somebody said 2015. And when I started talking about the history of the timeout, the ARN involvement in that, people were genuinely surprised to learn that, timeout was introduced by, developed by ARN in 2004, 2005. And I also told you that I happen to know my good friend and mentor, Bill Duffy, who was a past president of ARN and who is considered the father of timeout. And, we had this excellent idea to record this podcast and invite Bill.
Yeah, and Andre, I was actually surprised because I didn't remember a time when there was no timeout. So thank you for introducing me to Bill. And Bill, why don't you tell us a little bit about yourself and your history?
Yeah, so I'm a perioperative nurse, obviously, and I'm a product of when I went to nursing school. The big thing was primary care. Where you were taught as a nurse, you owned your patient and you nursed them through the stay. And so when I went into the operating room, I had that primary care mindset. And back in the day, the Joint Commission came out with the never events. This list of things that you shouldn't do. And one of the never events was don't do wrong site surgery. But the Joint Commission never said how not to do it, Right. And so that was great to say. It's like your parents, like, don't touch the stove, but they didn't tell you, what to do to not touch it. So anyway, I was just elected president of the association. And I said, well, we're the nurses. Why don't we decide what to do, and we'll form a partnership with the other people in the physicians and anesthesiologists. And so, people say, oh, we can't do that, we can't do that, we can't do that. And I think the timeout process is really a great example of how, we do have the ability to change policy and influence policy if we just try. And so we worked with Dr. Lucian Lieb, who is a patient safety expert out of the Harvard Public School of Health. And he said, oh, I'd love to work with you nurses. I love nurses. And so we developed a toolkit, and then we went to the American College of Surgeons. We went to the anesthesiologist. We went to the surgical technologist, and we said, hey, we have this idea. Will you partner with us? And we were very careful not to say, we have this idea and it's our idea. We said, we have our idea and we would like to partner with you. And so it wasn't like we were telling them what to do. We were looking for partnerships. And so they all signed on to it, and the Joint Commission signed on to it. And then we did a public relations campaign where we actually went out and told the public about it. And it went from, every hospital having different ways of identifying a site to making it standardized, not only in the United States, but actually it's adopted around the world.
And this was in 2004?
2004. The first time out was in June of 2004, National Timeout Day. And it was funny because I spent 2 weeks, doing my Andy Warhol 15 Minutes of Fame. I would fly around the country doing interviews, all these, early show on CBS, Fox National News, the Wall Street Journal, USA Today, National Public Radio. And it was great because we really, as nurses, went out and tried to help the patient, saying, you should be looking for this when you come in and have surgery. So we not only had the healthcare workers working on it, we invited patients to get involved in the process as well.
So did you get any pushback from it?
Oh, sure. Absolutely. Like with many things, there's organizations are made up of individuals. And so while organizations like the American College of Surgeons, for example, was 100% behind it, but there were a lot of surgeons in individual hospitals who said they didn't need to do it or didn't want to do it or didn't want to be delayed. And the nice thing is that, usually we had champions. The fact that we formed those partnerships, we would have champions from anesthesia or from the surgical technologists. So it wasn't just the nurses and this reluctant surgeon discussing it. They were arguing with the team, and it's harder to argue with a team than just an individual. But no official organization resisted it.
And so how did it grow to where it is today? You've been involved, obviously. ARN was what pushed it, but it's certainly, I don't think everybody really understands that ARN was the organization that pushed it in the first place. That's grown.
And it's much different because now it involves the fire safety and it involves making sure you have all the proper implants and things. When we first started,
antibiotics.
Yeah. And I'm sorry, Andre, for probably talking too much, but so it has grown as people, said, oh, wait, this is a tool that we can use to make sure we have other things that are a problem in the operating room. But really, I think what was one of the key catalysts was the World Health Organization developed a checklist manifesto, and they actually incorporated our timeout process into that. And I always joke the biggest mistake that ARN or I made was we didn't write a book about it, because then Dr. Atul Gawande, became famous going around giving lectures about the checklist manifesto. So, as nurses, again, we don't necessarily think about, we try to help our patients, but we weren't thinking necessarily about writing a book or anything like that.
Or trying to take credit for it, or making a big deal about taking credit for it. Yeah.
Yeah. And I think that's a problem, too, is why people think, 2010, 2000. And that might have been around the time that Dr. Gawande was talking about the checklist manifesto. So, we don't really do well about marketing ourselves as nurses in general. We tend to stay in the background and do good work. And then we wonder sometimes about why our value isn't necessarily always appreciated.
This is fascinating, Bill, and this is, I do agree. I do remember the time when the book came out and he was doing a book tour to Gawande, and it was about the time, it was 10, 12 when it was there. But I wanted to come back to how the organization went about getting support for the idea. The fact that you didn't come to all these organizations and say, hey, this is our idea and we really want to do this. And I think it is what emphasizes that we always focus on the patient right first and what is best for the patient versus like who gets the credit for that. And I really applaud you for doing this. This is really tremendous. And I want to touch back on John's point too, like how this idea really became from the grassroots movement to like widespread. I think that, can you talk about when you actually, when their AORN mailed the timeout kits to all the members, which was, I think, the catalyst, and of all the articles that I've read, I think that really stood out for me.
Yeah. So again, I think, if you've probably heard this analogy, is that there's a bunch of nurse scientists who are working on improvements in care, but there's a gap between what our nurse researchers are working on and operations. And so it takes, sometimes a decade for a new way of process of doing something that can really help patients to translate from the research that the scientist is doing to actually getting incorporated into practice. And, that's why the DMP role was kind of created, was to help with that transition. So what we thought about is AORN has a great history of developing all these recommended practices or all these improvements, and then they get put on a shelf because a new president comes in and starts working on something else. So what we said is, what we got to do is make this be alive. And so instead of charging anybody for it, we decided, let's create this toolkit and then give it away for free. Because the whole idea was to make sure that patients don't have a wrong site procedure. And we said to our members, here's a way, if everybody does this, no matter what hospital that doctor or surgeon is going to, or that anesthesiologist, or if you're a travel nurse or something, everybody will be doing it the same way. And that then you have some standardization and some rigidness in the process. And so it cost us a ton of money. We took about 25% of the AORN reserves to not only develop the toolkit and market it, but then also to give it away. But one of the things we found really amazing is a month after we did the timeout, we got requests from Europe and Asia for the toolkit, from hospitals in Europe and Asia saying, hey, we hear you got this thing, can we have it? So we've started mailing it around the world. I actually do have some pictures when I've been overseas speaking. I saw timeout in Arabic, I saw it in Korean, I saw it in Japanese, and I saw it in Chinese. So people have taken what we've done and translated it into their language and then are using that in their operating rooms, which is really pretty cool.
So Bill, what did the initial timeout require? As Andre indicated, we've added a whole bunch of things to it, and we keep adding things to it. Pretty soon, it's going to be a half-hour project, I think, in the operating room. But what did it include in the beginning? I'm assuming it was much simpler.
It was identifying we had the correct patient,
right?
That we had the correct site, that the site is marked, and that the consent and the site marking matched, and then that you confirmed with an X-ray if there was an X-ray present. So it was really, though, mainly about the site and the patient when we originally started it.
And where do you think we're heading in the future? Now, of course, now we have a National Timeout Day. I don't remember when that was implemented, but obviously
2004.
Oh, was it? Oh, at the same time. Gotcha.
Yeah.
And so where do you think it's heading now? It's obviously grown its own wings now and, is extremely popular. WHO, of course, when they picked up on it, definitely made it international. But where do you see it going from here?
Yeah, I think it has to go, and I don't want to say that I'm not quite sure what the proper phrase is, but I think it has to go back into itself. Uh-huh. The problem is that, as Andre has said, a lot of the new generation of providers are unaware of its history or why it was created, and we still have wrong site surgery happening every day, and the Joint Commission still reports that it's one of the top 10 medical errors. So people are. I think one of the challenges we have as being healthcare experts is that many times experts think that they can manage things and they can multitask and they can do things. And so every time I've been involved with someone who has been in a wrong site procedure, they all talk about how shocked they were that it happened. And I think sometimes we get into routines and people are just assuming the process is going to work instead of working to make the process work. And so I think it has to get reinvented a little bit.
So Andre and I, of course, are in the ASC industry, and the timeout was universal across all surgical specialties. But Andre, why don't you talk a little bit about the role in ASCs and how that evolved?
Yeah, John, thank you.
And the importance of it.
I think that this is a very important topic for the ASC. Obviously, we are a volume-driven operation, right? We have a lot of busy ASCs, either with ophthalmology or we have a full day of carpal tunnels and full day of knee surgery, and the laterality is super important, right? And I think that this is the time when we really stop and we emphasize it to our teams. We want to make sure that anybody can speak up during that moment.
Yeah.
And I think that the one thing that I'm really encouraged about, that I see more and more physicians that really embrace this. Like, it used to be like, hey, do time out and I'm still gloving or gowning or I'm doing something and I'm, and now I see more and more physicians that are actually support the nurse, during the timeout and say, hey, please, everybody stop, finish your stuff, and then we will do an x-ray. Then we will do whatever you need to finish your stuff. And I was recently in a pain room and I was talking to a provider who was doing a full day of pain injections, and every single time the timeout was perfect. We stopped. It was a silence, and the nurse and I complimented him and I thank you for supporting our efforts. And he's like, no, I'm really taking it seriously. And It didn't used to be like that, and now I'm really taking it very seriously. So I think the timeout is an extremely important. We drive this with our teams. We drive this with the anesthesiologists and the surgeons. That this is the time when. We're taking a moment for patient safety, and we are very supportive of it.
What's still shocking to me as a surveyor, though, is that it is still problematic. Now, part of it is that we keep adding things to it, and everybody, I think they understand the importance of a timeout, but as we keep adding things to it, my fear is that we'll kind of forget what the origins, what the main purpose was behind it. I see you kind of nodding your head, Bill. By the way, we record this using Zoom. This is, of course, only an audio recording. I wish everybody could see Bill's expressions. Very animated.
Got to show him alive, right?
Go ahead, Bill.
No, I was just going to say, I agree with John. I think, and that's when we first started it. We wanted to focus on the problem of the wrong site procedure. And believe me, I understand fire safety is a challenge. And so the other things that are being added on, kind of rub up against the idea when people are looking for efficiency and to have an environment where they can be able to do the procedures and then get back into the office and see more patients. And so, we do have to find that way with not going where it becomes too burdensome that people push it away. But we also have to make sure that people embrace it because, I don't know if you ever had to do it, Andre, but I know as a chief nursing officer, trying to explain to a family that, the surgery was done on the wrong leg or something. And they're like, how can that happen? And, you guys, don't you know what you're doing? And it is that problem when so many people are getting focus too much on efficiency where they're forgetting that there's a human being that's putting their lives in their hand when they do that. So it is a delicate balancing act to be able to have people embrace it where we don't, but also not make it too burdensome.
So I guess my last question is, we're not completely there yet, even though we're 22 years, or 20 years after. This is the 20th anniversary, I guess I just figured out.
Yeah.
20 years later, and yet it is still a challenge. So I'll ask both of you now, what are your final words to our audience about why we did this and perhaps how we can take the lesson of the past and the history that we have, the rich history we have from ARN and all the work that was done with WHO into the future?
Well, I'll just say, I think one of the things we have to do is that we, as the perioperative providers, have to celebrate our past and celebrate our history and values. The fact is that many people don't know that this was, developed and it's 20 years old. That's our problem, is we do things and then we don't really talk about the tradition and the value with that. And so people tend to forget it and they don't see it as something important. And so one thing I would say we have to do is we should be celebrating them. It is the 20th anniversary, as a team in the operating room, we should be celebrating that and making people aware that there's a reason why this was instituted.
Yeah, I wish we had thought of this before the actual week, but it's just as good to get the word out there afterwards and talk about the experience.
Absolutely, and I would echo Bill's sentiment. I think that it is very easy to kind of take it as for granted that it is always there. That it's and a lot of nurses that entering the career, this year, they would never know that this is only 20 years old, and we really need to cherish that. And for that reason, we really need to celebrate the Time Out Day. We need to educate our folks, and we really need to continue building alliances with physicians and understand how important it is. The last, I believe, the last Joint Commission report was that there's still 900 wrong side surgeries were reported in the last survey. So it is incredible that we're still dealing with this, and I would echo Bill's sentiment that we have to cherish the time out, protect it, and build alliances with all the providers to support it and do it the right way every time.
I want to thank both of you for this wonderful interview, and thank you so much for giving us the history behind this and emphasizing the importance of it. This has been great.
Yeah, thanks.
Always a pleasure. Thank you, John.
Thanks.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
And, of course, the Administrators Bootcamp is July 16th through the 19th, presented virtually. For more information, visit ASC-Central.com.
The Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 17th through the 19th in Orlando, Florida, at the Signia by Hilton, Orlando Bonnet Creek.
The Texas Ambulatory Surgery Center Society's annual conference is July 24th through 26th in Galveston, Texas, at the San Luis Resort, Spa, and Conference Center.
The Georgia Society of ASCs and South Carolina ASC Association's joint semi-annual conference and trade show is August 15th and 16th in Hilton Head, South Carolina, at the Marriott Hilton Head Resort and Spa. And the 2024 Illinois Association of Ambulatory Surgery Centers annual meeting will be held August 22nd to the 23rd at the Crowne Plaza Chicago O'Hare Hotel in Rosemont, Illinois. And I'll be doing an ASC Administrators Workshop. I think it's a 4-hour workshop during that conference. The California Ambulatory Surgery Association's annual conference is September 4th through the 6th in Anaheim, California at the Anaheim Marriott. And Sue and I are still trying to work this out to see if we can go out there this year. It's been a couple years since we've been there, and we really enjoy our time out in California, but we might not be able to get it into our schedule. And the Tennessee Ambulatory Surgery Center Association's annual conference is September 12th through the 13th, 2024 in Chattanooga, Tennessee at the Chattanoogan. The New York State Association of Ambulatory Surgery Centers annual conference is September 17th and 18th at the Desmond Hotel in Albany, New York. And Ambulatory Healthcare Strategies will be doing a pre-conference, which is 3 credit hours of additional education on Monday the 16th, and that will also be our annual New York State client conference for clients of Ambulatory Healthcare Strategies. And Becker's ASC 30th annual meeting is the Business and Operations of ASCs, is going to be October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency. The Washington Ambulatory Surgery Association's 2024 Annual Education Conference and Trade Show will be November 7th and 8th at the Tulalip Resort and Spa in Tulalip, Washington.
And I'm going to be speaking about accreditation and provide an update on accreditation trends at that conference. I always enjoy going out to Washington. I enjoy going to all these conferences, but Washington is an interesting conference there. And on-demand versions of the ASC Director of Nursing and ASC Administrators Bootcamp and our Business Office Managers Bootcamp are available on our sister website at ASC-Central.com. And we do want to, we've referred to this a couple times in the podcast here, but we want to remind everyone to become a patron member of the podcast. The patron member program, which is available on ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for business administrators, nurse managers, and business office managers. And in addition to our regular, usually weekly drop-in Zoom sessions on Saturday mornings with other patron members and the staff of the podcast, there are additional patron resources, including some of our more popular virtual conferences, and example policies and procedures, example forms, and our famous fire and disaster drill kits. They're a lot of fun. A membership in the patron program helps defray the costs of producing the podcast, including research staff, travel costs to conferences, equipment costs, and production costs. And for more information, you may wish to visit ASC-Central.com. And I think, Sue, we're getting very close to 200 patron members at this point. There's no easy way to calculate them because they come in different programs there, but it is quite a growing program. I do want to thank you all for joining us for this episode of the ASC Podcast with John Goehle. And if you found the episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And please don't forget to hit that subscribe button so you never miss an episode. And we would love any feedback about our episode or ideas for future episodes, especially if you'd like to see more of our skits, too.
Can you tell John is just chomping at the bit
know.
here?
I really had fun doing that. For those that don't know anything about me, I used to direct plays. And Judy D'Ambrosio, who was the first, one of the first co-hosts here, she and I met, actually, while we were involved in plays.
Yeah, I won't be acting, so we'll have to pull in some of our other, maybe some of the grandkids.
That's true. I think we could have a lot of fun.
Dramatic.
So if you want to give us feedback, please send us an email at comments@ascpodcast.com.
We'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Caloritas, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Fody, Donna Macchio, and Christina Norman. We couldn't do it without them.
That list keeps growing, Sue. Have you noticed that? I fear that we might have forgotten some.
Yes.
That's right.
To do that.
And our music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ASCPodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.